Welcome to today's GNCC Espresso Live with our distinguished guest, the Acting Medical Officer of Health for Niagara Region, Dr. Hirji. Dr. Hirji, as always, thank you very much for being with us. And to all of our participants, I'm really glad that you were able to join us. My name is Mishka Balsam, and I will be your moderator for the next hour. Today's webinar is actually the last one in a series of ones that we have held with Dr. Hirji. I looked back at my records earlier today to see when the first one actually took place, and it was at the end, I think it was around October of 2020. And it was all done in an effort to assist the business community with the ever-changing rules, guidelines, and to answer any questions that were actually coming forward, because we were charting a territory that was filled with uncertainty and a lot of misinformation at the same time. So I would like to take this moment to extend my thank you on behalf of our members and the larger business community to you, Dr. Hirji, for being with us, to share your expertise and provide us with all the necessary insights that were needed in having a greater understanding of the decision-making process and the levers and drivers behind all that we have experienced. So thank you very much. We all found ourselves in unknown territory. We saw shifts in decision-making. We saw rules about masks, vaccines, travel, self-isolation, and in so many other areas. But if I really look at it and saying if there's one thing that I can take away from it, I think is that we have learned over the last 2 years how interdependent we are and how much our social areas and aspects of our life impact our economic one at the same time. And we can't isolate them anymore. Currently, a lot of the conversations have shifted. We're looking currently what is happening worldwide. Is there vaccine equity that exists or not? How do we overcome it? We ask ourselves questions, is it time for Canada to end the last remaining travel restrictions that are there? We're listening to the provincial election time that we're facing right now, and we're asking ourselves what are the future needs of our healthcare system. So a lot of what has happened over the past 2 years is really still driving today's conversation in an effort to continuously actually ensure that we have the services that each and every Canadian actually needs. With that in mind, let us move forward actually for today's program as we have it. Many of us and many of you have provided us with questions, and we're committed to getting to all of them. If you wish to enable live transcript, please refer to the bottom of your Zoom screen for that option. But starting out, as always, I'm going to pass it over to Dr. Hirji, who will provide us with an update. Thank you.
Thank you so much, Mishka, and thank you for that introduction. Thanks for doing these, but I think also for your, really on-point comments about how the pandemic has taught us how interrelated everything is, particularly, for my interest, health and the economy and society as a whole, but I think in many different ways we found out how interdependent we are. And I think some of my comments will probably touch on that going forward. So I've got my slides up. Hopefully everybody can see it. If you can't, please do give me a flag at some point as we go forward, and I will get started. I want to spend a little less time today probably talking about the updates and trends, because I think those are fairly straightforward, but maybe taking a bit of a longer term look at what are the ongoing challenges I see us facing from the pandemic going forward. I'm going to start here with, I believe I presented this last month, and this is the modeling that the Ontario Science Table has shown what we could expect from the current wave. And what they were predicting here is that hospitalizations would peak in the early part of May before starting to go down, and that peak would probably be less than the previous wave that we went through in January was. So, maybe something closer to this green line, but nonetheless, it would be significant. I think what we see is that this is basically what has panned out, that we've hit a peak in this wave through the early part of this month. We are now on the downward swing. All told, this wave wasn't as bad as the wave from January, but it shouldn't be, I think, discounted. So, starting off just looking at what the provincial wastewater trend is looking like, you can see the wastewater signal is kind of a proxy for how many infections we had, and we can see that that is on its way down. Unfortunately, didn't reach the same peak as that January wave with Omicron. When we look at our breakdowns by regions, though, there's a little bit of a slightly worrying sign where you can see in a lot of regions here, there seems to be this flattening out, or in some cases, even an increase. We're the Central West region here, where we're flattening out here. And what's significant is that I don't think we want to flatten out with infections quite this high yet, and hopefully we can get it lower down to something more similar to what we may have had at previous point in the pandemic, such as the summertime. I'll just show you on this next slide here, where we're looking a bit deeper dive here in Niagara's wastewater treatment plants. This is the Port Weller wastewater treatment plant in St. Catharines, and you can see we went up and we do seem to be on a downwards trend, and we didn't have quite those high spikes that we had in the January wave, but we're still well above where we were through the fall and especially through the summer last year, when we had quite low levels of COVID-19. And of course, in the latter part of summer, we were able to be largely fully open. And that's where I hope we can get to at least some point this summer, so we can get some reprieve. Looking at the well and wastewater treatment plant, kind of a similar story. We went up and we're on our way down here. Still, of course, at this level, far higher than we were last summer. Niagara Falls wastewater treatment plant, again, similar kind of pattern. We went up, we're on our way down, but not really down to the levels where we were last summer quite yet. Looking at our raw case counts of people who get PCR testing, that is on its way trending down. Recognizing that we're not testing everybody here, so it's probably a true number of infections is higher than this. And of course, while this is trending down, it hasn't got down to where we were in the fall or where we were the previous 2 summers, which is where I hope we can get to. The Niagara trend of cases, pretty much the same thing. Had the wave, we're on our way down, but not quite down to where we were in the past summers. The percent positivity, I think, gives a slightly better sense of what might be the underlying trend, taking into account the reduced testing we have. But we can see, fortunately, that percent positivity number here is on its way down. But of course, it remains quite high, higher than we were in the fall or in the past, at least the last summer that's on this graph. The Niagara percent positivity likewise on its way down, but still far higher than we were through the fall or through the previous 2 summers, which is where I hope we can get to. Looking at our outbreaks in Niagara, we can see we peaked kind of that early part of May again. And fortunately, we are seeing a decrease in the number of outbreaks as well. So all the trends are really pointing at things are getting better. Here is the hospital data from the province, and we can see we nicely peaked in the hospitalizations. It looks like we are on our way down, but of course, the number of people in hospital is still not down to the lows of the fall or the past 2 summers. And that's the ICU numbers, which fortunately didn't rise nearly as much with this wave. Same kind of story here. This is the hospitalizations from Niagara Health and the ICU numbers from Niagara Health. I think it's basically the same story. Just highlighting that, even with it coming down, because we still have a fair number of hospitalizations, we're still seeing people being hospitalized at the rate of about 2 per day. 2 per day. And you can see that's still higher than we were, back even, between these 2 waves, back in the fall or back last summer. And so there is a bit of a ways to go down, and particularly noting that our hospitals remain over capacity in terms of the number of people admitted. And you can see that they've basically been over capacity since the fall of last year. So this remains something that is stretching our hospitals. And then finally, looking at deaths, which is, I think, the worst of the outcomes that we would see with COVID-19. And we can see that we do seem to have peaked in the number of deaths, but sadly, many people are still dying of COVID-19. Far more than we were seeing through the fall or last year, far more than we saw in the summer and the previous year. So we do still want to be taking this pandemic seriously, because people are still dying. There's still more we can do to hopefully protect them without, of course, disrupting the economy and having some of the more onerous measures we've had to go to in the past. And likewise, here are the deaths in Niagara. We fortunately don't report a death every day, but how high this bar is on any given day, how many deaths we reported. So this is the January wave, and this is our more recent wave. And you can see, of course, people have been dying over the last couple of months. Just yesterday, we reported, unfortunately, 3 additional deaths from COVID-19. And I've talked about in the past that, unfortunately, where we see people dying is not necessarily very equitably distributed in our society. And so this is looking at economic quintiles here across our first 5 waves of the pandemic. Quintile 1 here is the lowest income. Quintile 5 is the highest income. And we can see consistently, as people get to lower income, no matter which wave we were in, people suffered more from the pandemic and passed away in greater numbers from the pandemic. And so one of the reasons why I think we want to find sustainable sustainable things we can do to continue to control the pandemic better and keep infections lower is so that we don't see these unequal impacts on our society. And of course, we save lives and protect people across our society. So that's where I want to stop in terms of talking about kind of the recent trends. I think the overall story is that we are fortunately trending downwards with this wave, but we're not all the way back down to a low level of infections, and we do want to get to a low level of infection. So we don't see people passing away in such large numbers. We don't see these inequitable impacts. And of course, we don't have all of the other disruption from the pandemic. And talking about some of that disruption is really what I want to do next. And I suspect there's many business owners and people who are operating organizations on here, and you're probably well aware, probably better than I am, of how much supply chain disruption has affected us. And there's of course many causes for the supply chain disruption. The war in the Ukraine is not exactly helping, but I think the root cause of many of this has actually been the pandemic. And some of what the pandemic has done through the course of the last 2 years has really started to slowly catch up on us as mounting supply chain issues. China is obviously still taking a very aggressive approach to controlling the pandemic, having only mixed success with that. And of course, that's making a major disruption. But even other countries, the illness caused by COVID-19, absenteeism when people need to isolate, is all compounding some of that impact. And looking forward, I think there is reason to worry that we're not necessarily going to see that completely lifted. So one of the things that we are seeing increasingly with the COVID-19 is that as new variants have emerged, and particularly these subvariants of Omicron and BA4, BA5 are two of the newer subvariants that are emerging, we're seeing people getting repeated infections from COVID-19 and people being repeatedly infected even just a few months ago. So, the Omicron wave was back in January, and unfortunately, sometimes people are getting reinfected even, just a few months later. And that, of course, means more people are isolating, people are missing work, people are missing school. And that's, of course, exacerbating some of those economic hardships and those supply chain disruptions. Another thing we're unfortunately seeing, and I'm pulling this up because this is something that I noticed happened in pop culture, is that we're seeing people basically having relapses of their infection. So they have COVID-19, they get better, and then a couple of weeks later, it seems like it comes back. And that might be a reinfection, but it may actually just be that original infection didn't completely go away. Your immune system kept it in check for a bit, so you felt better, you came out of isolation, you went back to work, etc. And then the immune system was no longer able to keep it in check, and it came in relapse for a bit, and people got worse. And we've had a couple of our late night talk show hosts actually go through that in the last little while. There's a lot of news articles a couple of weeks ago around this study that came out of Alberta, looking at Alberta and Ontario, which is really looking at people who've been hospitalized for COVID-19, they've gotten better, they've been discharged, and then nonetheless, within a short period of time, they unfortunately pass away or actually get readmitted to hospital. And the number was really thrown out that about 10% of people are seeing that. If you go into the study, it's about 1 in 9 discharged patients died or got readmitted within 30 days after their initial hospital discharge. And so, the COVID-19 infection unfortunately seems to be playing tricks on us where it, affects us, we think we're better, and it doesn't go away. And whether we're dealing with this relapsing infection or people getting repeatedly infected only within a few months after, I think that's going to be a cause for some ongoing disruption. And of course, the lower keep infections, perhaps the better we're going to be in terms of preventing some of that. The New York Times last week had this really in-depth article around the reinfection issue we're seeing. And I thought some quotes from this were actually worth pulling out because I think it talked to a bunch of scientists and got their sober assessment of where we're headed. So the virus shows no signs of disappearing, which I think we all knew. Variants that are adept at dodging our body's defenses and waves of infection 2, maybe 3 times a year. Some people are warning that might be the future of COVID-19, that we're going to have multiple waves of infection each year. Fortunately, thanks to vaccination, we can go through a wave as we've just been through without necessarily having to close businesses, put capacity limits, and have some of those more onerous measures in place. But nonetheless, going through a wave, having people sick, having customers sick is not going to be very helpful, of course, for our society really returning to normal. People who've already been infected may go on to have third or fourth infections even within 1 year. And some small fraction may have symptoms that persist for months or year, a condition known as long COVID, which we've talked about, and I'll talk about a bit more. And this scientist here at the Scripps Institute in San Diego is warning that if we manage COVID-19 the way we are managing it right now, then most people will get infected with it at least a couple times a year. And he'd be surprised if that's not how this plays out. If reinfection turns out to be a norm, the coronavirus is not going to simply be this wintertime once a year thing. And it's not going to be a mild nuisance in terms of the amount of morbidity and mortality it causes. And an infection with Omicron produces a weaker immune response, which seems to wane quickly compared to infections with previous variants. Although the newer versions of the variant are closely related and they vary enough from an immune perspective that an infection with one doesn't leave much protection against the others, and certainly not after 3 or 4 months. And so, really the big warnings here is that we might see repeated waves of infection and of course the ongoing disruption from that. And whether it's the repeated waves of infection or people getting those relapses of symptoms, I think that's going to be worrying. I don't think that's really the society we're all hoping we're going to be living in post-pandemic. And I think to me, that's the case, that we need to find more things we can do to control the pandemic in a sustainable way, which is not actually disrupting our lives, because we want to find a way where we can control the pandemic so we have as much freedom to go back to our lives normally as possible. And I think currently we're, as Christian Anderson highlighted here, we're probably on a trajectory where we're going to see multiple waves a year, and I'm not sure that's necessarily the optimal way of us returning to some semblance of normal. The other thing I want to talk about then is long COVID, which I've highlighted in the past. Long COVID happens particularly in unvaccinated people, but also in vaccinated people. And as highlighted here, this is from the Ontario Science Table. Conservative estimates suggest at least 10% of unvaccinated people will develop this post-COVID condition. I've seen other estimates that are closer to 30%. There's been some that are even a little bit higher than that, but certainly a significant number of people are going to suffer from this long COVID, particularly if they are unvaccinated. And this is a graphic they showed showing, all the different kinds of symptoms that people can experience from long COVID. I think kind of this, fatigue, the kind of brain fog, headache, those are sort of the ones that I think people are most familiar with hearing about. Long-term loss of taste and smell is another one that people hear about. There's fortunately been more research coming out on this over the last couple of months as we've started to understand a bit more what's going on with long COVID. And so this is a study here of long COVID that looked at over 120,000 people. And I think this was largely done in Italy and the UK in terms of what they're seeing with long COVID. And, again, showing all the different kinds of symptoms that people occur. A whole bunch of symptoms here are really, related to the brain, concentration, loss of smell, cognitive impairment, memory deficits, etc. But mood issues, breathing changes. Some people struggle with that. Some people have long-term changes in their cardiac function, and that's quite widespread what people may suffer from this. And just to zero in on that cardiac issue, this is some data that was put out in that another study here, and I just want to highlight the kind of numbers we're dealing with. And so I'm going to zoom in here on heart failure. You can see there's a breakdown, non-hospitalized, hospitalized, ICU. Obviously, the more severe your COVID infection, if you're hospitalized, you're in an ICU, you're going to be more likely to suffer these cardiac issues. But if you're looking at heart failure, this is probably about 5 or so on this scale. So out of 1,000 people, 5, or put another way, 1 out of every 200 people in the next year is going to develop heart failure that otherwise would not have developed heart failure. So that's a fairly significant number, especially when you consider that we're probably seeing several hundred people in Niagara every day getting COVID-19. We're probably seeing another 1, maybe 2 people every day becoming likely to develop heart failure within the next year. There's going to be people developing heart attacks, atrial fibrillation, strokes, pulmonary emboli, all kinds of these conditions. And of course, the people who get hospitalized or end up in an ICU are going to be even more likely to suffer some of these impacts. So some pretty significant impacts of what long COVID could mean for people. And of course, that's going to be a long-term burden on our healthcare system. If people are sick, they have chronic diseases, that's going to impact their ability to fully function in society, be part of our economy. It's going to be kind of this long shadow of what the pandemic may leave in its wake. Now, this study here in the United Kingdom, where they actually did MRI imaging of people, and they looked at people with MRI images in the past and then repeated an MRI after they had COVID-19 to see some of what they could see as changing. And I'm just going to zero in on this. And this is called the left orbitofrontal cortex. It's a part of the brain kind of, up near the front. And it's of interest because this is actually part of the brain that's associated with taste and smell. And what you see in this teal colored line is really what we see in most people. And you can see this is age of people here. And you can see that if we do MRI on people who are just normal, haven't, had COVID-19 infection, you see kind of a similar amount of brain volume in that orbitofrontal cortex. Once you get to elderly age, there does seem to be this increase, and this has long been known that happens at elderly people. The brain remodels a little bit, and it looks like this orbitofrontal cortex increases in thickness, and you have a bit more brain mass there. What we see when we look at people with COVID-19 is that their thickness of that left orbitofrontal cortex is less than people who have not had COVID-19 infection. So the brain structure has actually changed. And as you get older, that level of change becomes even wider. And so what COVID-19 seems to be doing is it's actually restructuring our brains in some ways. We know that people have those long-term issues with taste and smell when they get long COVID. So that kind of makes sense here that the center of the brain is associated with long COVID or associated with loss of taste and smell. We're losing brain mass there. And that's why some people are maybe losing that taste and smell. And they highlighted actually in the study several other areas of the brain where there are changes occurring. And so there are some pretty significant, I think, and worrying impacts of what ongoing COVID infection could do to us over the long term. This is another study which you may have seen news articles about a couple weeks ago, looking at describing that cognitive impairment from long COVID is equivalent to aging 20 years, a study found. Just diving into the study, I think it's maybe slightly exaggerating what the study actually shows, but I think the core idea is correct. So what they're doing here is that we have a set of different kind of tasks that people can do, and they're looking at accuracy and they're looking at latency. So they're giving the task, how long does it take for the brain to get it done? How accurately does it get it done? And you can see that across these tasks, pretty much all of them, the accuracy has fallen, except for when it comes to spatial planning, where it seems like people actually did become more accurate. And then here you can see that across those same tasks, largely, people's time to get that task done actually increased. And this is kind of the summary measure. So accuracy has gone down of doing those tasks. The time it took to get those tasks done has gone up. And these three asterisks basically means it's statistically very significant, and statistically it would not be explainable by chance. So we're seeing is that unfortunately, because of some of those impacts of COVID-19 on our brain longer term, people are becoming less accurate and taking longer to get tasks done. And then, this is that same graph here. We're looking at the accuracy lines here. We're looking at those latency lines here. And this is what we just saw with COVID-19, but shrunk down into a really small graph. What they're now doing is they're comparing a 70-year-old to a 20-year-old and seeing what are the changes that happen between age 20 and age 70. And you can see that over that 50-year span, yes, you see quite big changes, which we kind of expect would happen as people get older, and they're much greater than what we see from the COVID-19 infection. A 50-year-old versus a 70-year-old, when you age from 50 to age 70, what they're saying is that the changes we're seeing are perhaps on similar size to the changes we saw from COVID-19. And so that's where we get the age 50 to age 70, the 20-year difference. So the change in what we're seeing in terms of cognitive function from a COVID-19 infection might be similar to what we are seeing at 20 years of aging, but I think it's only applicable from age 50 to age 70. I don't know if that's necessarily an age 20 to age 40-year-old is necessarily going to show that same difference. They show here for reference the kind of changes that occur with dementia. You can see they're kind of analogous changes, fortunately not as severe. But I think the key takeaway is that COVID-19 infection isn't benign. It's actually having a longer term cognitive impacts on people, particularly I think on people who are unvaccinated. Another thing you've probably seen in the news was, 2-3 weeks ago, a lot of talk about this mysterious childhood liver impact hepatitis that we are seeing in a lot of different countries. Few of those investigations are happening in Canada. One thing we know from other countries when they've gone through waves, and I highlight this, is India, when it went through a big wave last summer, is they saw an increase in hepatitis in children associated with COVID-19. And so the thinking is by many that these increases in hepatitis that we are seeing right now, this is because many countries have lifted their COVID measures. Partly rightly, I think we had to get to a point where we weren't going to have those in place, but did it at a time where they maybe didn't keep enough in place or didn't have other protections in place. Lots of children got sick, and unfortunately, some children are now getting, this hepatitis in children, which we've seen in other countries, and it's actually a direct consequence of COVID-19. Now, of course, we have tens, hundreds of thousands of children infected around the world with COVID-19. 228 cases of hepatitis isn't, of course, overwhelming. Fortunately, this is very rare that it's going to occur. But nonetheless, this is another example of how I think COVID-19 is going to cast this shadow for a while. And the best way for us to address that shadow is going to be to get some longer term protections in place that can keep us protected from COVID-19. And as this person here is highlighting, that surviving the pandemic is only half the battle. Dealing with the long COVID that's going to affect perhaps 1 billion of us over the next few years is going to be part of the battle that we fight going forward, in the kind of legacy of the pandemic going forward. I think we can get a little bit of insight into some of what that's going to look like. So, I've highlighted in the past how Canada has done much better than other countries in controlling COVID-19. So if we're looking at our cases of COVID-19 here in Niagara, that's the green line. And then this is the United Kingdom. And we can see that pretty much throughout the pandemic, the UK has done far worse in controlling COVID-19. They've had bigger waves. They've had periods of lots and lots of infection occurring. And we can see particularly here in the fall, they had lots of infection going around and then had big waves. And going into the early part of this year, I highlighted actually these two articles a few sessions ago, where long COVID was being described by UK employers as a major cause of long-term job absences, and by a quarter of UK employers that was occurring. And I think, as I just shown you, with seeing what are the impacts of long COVID, that kind of makes sense. There's a fair number of people who are going to be suffering these long-term systems, sometimes, be it cardiac, be it cognitive, that's going to really impact their ability to function as well in society. And that's having a direct impact on employers and the economy. And I just saw this actually put out a couple of weeks ago by the Bank of England, which was looking at population age 16 to 64. So basically the workforce, or people eligible to be in the workforce who don't want a job because of long-term sickness. And you can see, it looks like the UK was making good progress in decreasing that over a long period of time. We get the pandemic here in 2020, and there's a big jump up, which kind of makes sense. More people are getting sick from infection, so more people are out of the workforce. But that didn't really improve over time, and it actually seems to be getting worse, over the course of 2021. And I just showed you in the latter part of 2021, lots of COVID was spreading. Lots of people are probably getting long COVID. And so long-term sickness is starting to really impact the UK economy. And the Bank of England is highlighting what this is looking like for them. And I think that is the worry that we could see if we can find a way to control the pandemic in a way that's sustainable. That's the measures we're taking on disrupting society, but we also don't want to have the infection disrupting society, and find that happy balance where we can keep everything open, we can have our society function normally, but we can also have things in place that are lessening the spread of infection. Obviously, chief thing we can do is make sure people are vaccinated, and vaccination makes a big difference here. This is a study looking at long COVID and looking at, this is actually a breakthrough infections here, and people who got repeated infections from COVID-19 and what that did around long COVID. And so the way this data is highlighted, so these are all the different kinds of symptoms you could get from long COVID. This dotted line is basically risk of someone who is unvaccinated versus someone vaccinated being equal. If something is on, a dot is on this side, this means you're less likely to get it if you're vaccinated. If it's on this side, you're more likely to get it. And we can see across all of these kinds of symptoms that people might suffer longer term from COVID-19, the dots are pretty much largely on this side of the line. And so vaccination is preventing those long COVID symptoms. We do see a few here that go above that line, but you can see these lines are actually coming and crossing that dotted line. which basically means it's statistically insignificant. This is kind of the error within the measurement. And so, symptoms, some of them might be equally likely after vaccination, but some of them are going to be less likely. And so getting vaccinated is absolutely going to be one of the things we can do to prevent long COVID, and making sure lots of people are vaccinated. This is just another way of looking at the data where this is time since your initial infection with COVID-19. And these are unvaccinated people developing respiratory failure here. And then these are the vaccinated people. And you can see less likely to develop those long COVID symptoms if you are a vaccinated person. And any feature of long COVID is not quite as large, but definitely the red line is lower than the blue line. So getting people vaccinated is absolutely one of the most important things we can do to minimize that impact of long COVID. If we're looking at hospitalizations from COVID-19, we can of course see the impact of vaccination here as well. I think there's a question that was asked in the one submitted in advance about the benefit of in getting immunity from infection versus immunity from vaccination. And this slide, I think, really speaks to that. I'll just highlight that, sometimes people say that immunity from infection is natural immunity. And I would argue immunity from infection or from vaccination is natural immunity, because in both cases, your body is actually developing that immunity. If it's getting the vaccine is teaching it how to do it. If the infection gets to you, the infection teaches your immune system how to do it. But in either case, the immunity is actually built by your body in a natural way. So we'll start off looking here. This is someone who's had infection, has had no doses of vaccine. And what is the risk of hospitalization thereafter with COVID-19? And sorry, this shouldn't be risk of hospitalization. This is the risk of not being hospitalized. So 66% chance you're not going to be hospitalized if you've had infection. If you have infection in one dose of Pfizer vaccine, so you got infection, you recovered, you got a dose of Pfizer vaccine, so now you have the benefit of infection plus one dose of vaccine, you're up to a 75% chance of not getting hospitalized. But if you got 3 doses of vaccine, which is what we recommend, you're up to 90% chance almost of not being hospitalized. And so getting your 3 doses of vaccine is the best way to make sure you're protected from COVID-19. Obviously, if you get infection, right away you have a chance of being hospitalized due to that initial infection. But it also looks like the immunity you develop is not going to be as good as the immunity you get from vaccination. And it's not going to be as good as even the infection plus then getting some vaccine after the fact. And so I think getting people vaccinated is absolutely the best thing we can be doing to make sure people are going to be protected from long COVID, from hospitalizations, from all the impacts of COVID going forward. Just a quick update here on what our vaccine coverage is looking like. So these are first doses here, blue are the second doses, green are our third doses, and then that navy blue here are people getting 4th doses. Since I last talked to you at late April, we actually got the latest release of census data. So the 2021 census data on how large each of these age groups is. So we've actually been able to update this data for the different census groups. And one of the actually nice things that I saw coming out of that is we actually now seem to have a pretty consistent uptake of first and second doses across most age groups, where we're basically at 90%, basically in the 80+ age group. And you can actually see here that's 2 doses, where at 90% of people have gotten 2 doses amongst that adult age group. So that's really good news. Where we're still lagging is in third doses, and particularly third doses for this young and middle age group. And I'm hoping we can get their third doses up. Our elderly group, we want to get them 4th doses, so there's still a ways to go there. And really, unfortunately, the 5 to 11 age group is an area where we still haven't seen as much uptake of vaccination as we would like. So hopefully we can see more of them getting vaccinated and making sure they have that protection as well moving forward, especially considering things like that hepatitis in children I talked about, which might be caused by COVID-19. Just want to highlight that there's been more studies around this issue about vaccination in pregnancy, which we've recommended and highlighted that people who are pregnant are at more risk. And more and more, you can see here the study found COVID-19 mRNA vaccination appears to be safe and is associated with a reduction in stillbirth. And so anybody you happen to know who might be pregnant and is uncertain about getting vaccinated, the data is absolutely showing that it's safe, and it's actually going to make sure that your child is going to be safer longer term during that pregnancy. Protection against hospitalization from COVID-19, just want to highlight the benefit of 2 doses versus 3 doses. And you can see the protection from 3 doses is higher than with 2 doses and doesn't wane as quickly with 3 doses. 3 doses really should be the standard we expect people for vaccination now. And even when we look at people's likelihood of transmitting COVID-19, if they unfortunately still do get sick, with 2 doses, they have much more virus that they're breathing out, whereas 3 doses are giving out a lot less virus. And so someone with 3 doses, even if they do get infected, they're much less likely to be spreading COVID-19 to others. So we really do want people to get 3 doses of vaccine. Quick update on what we're seeing in terms of vaccine uptake. We are continuing to show reasonably higher vaccine uptake right now. A lot of this is people getting 4th doses. Hopefully we can get more people to get their 1st, 2nd, and 3rd doses as well, but we're fortunately doing better than we were maybe earlier in the year where our uptake was much lower. Vaccination then, biggest thing I think we can do to make sure we get more people vaccinated with those 3 doses will reduce infections, reduce the long COVID, reduce the hospitalizations, and really help us get to our, COVID-19 being more sustainably controlled in our society. I've talked about in the past, some of the other measures, and of course I have this op-ed I wrote where I've talked a little bit more about that, and I'm not going to go into that at this point. I think while we're still dealing with high infections, wearing masks remains something really useful to do. Antivirals, I know there's a question around antivirals, and one of the other good things we have now is we have these antiviral treatments for people who are high risk of getting COVID-19. And if you go to this website, you can actually fill out this tool to find out if you're eligible for an antiviral treatment. Key thing about antivirals is, as it highlights here, these treatments must be taken within the first 5 to 7 days of your symptoms starting. So if you get symptoms of COVID-19 and it's not too bad, you don't worry about it, and then 5, 7, 8 days later, now you're feeling much worse, at that point, it's too late to get antivirals. So if you're someone who thinks you might be higher risk, I absolutely recommend that the first sign that you have any signs of COVID-19, take a rapid test, find out if you have the infection, and then go fill this out to find out if you might be eligible. If you are eligible, you want to get in touch with your family doctor right away so they can get the testing, they can get the paperwork done so you can make sure you get that treatment right away, because time is of the essence for that treatment going to work. Just highlighting, we've had a study recently that's looked at ivermectin, which we've all said is not an effective treatment for COVID-19. We now have a study published in the New England Journal of Medicine, which is the most prestigious medical journal in the world. Treatment with ivermectin did not result in a lower incidence of medical admission to a hospital due to COVID-19. So ivermectin absolutely doesn't work. If you know anybody who's thinking it does or is still unsure about that, I think we can put the nail in that coffin, hopefully. Now, I've talked a bit about keeping workplaces safe in the past, and I still recommend vaccine policies and updating them to 3 doses as being a good practice to have. Improving ventilation filtration, that is going to be really key to getting these airborne virus out of your spaces to make sure there's a minimal amount there to protect workers and customers. I talked about mask policies. I think they remain a good thing while we still have lots of infection going around. They're a little bit of a nuisance, but they do protect us, and we can still be open and do everything while wearing masks. We need to continue to have a culture of staying home if sick, and I really encourage that employees should be screening themselves for symptoms and not coming to work if sick so they don't spread it to others. And if we can have sick time options for employees, remote work options for employees, so if they are sick, that they don't feel pressured to come into the workplace and therefore aren't spreading infection to others, I think that's something you want to continue to support. And I'd really like to see, some provincial supports here to make sure all employers can have paid sick time. And I think it'd be sensible that we will expect more waves of COVID-19, as I highlighted, and we want to have surge protocols to deal with that. And I'd suggest that when we see a wave of COVID-19, make sure you have a policy of people wearing masks then, maybe screen visitors, maybe go back to doing some rapid tests, encourage people to keep physical distance voluntarily, and maybe move some of your meetings to virtual to really try and limit the potential during those waves of infection spreading. And then, of course, when the wave ends, we can stop these surge protocols and go back to some of our more usual activities. Last thing I just want to quickly talk about is rapid testing, because there was a few questions submitted about rapid testing. One question is, how effective is rapid testing? And so this is the rapid testing, and this is looking at a Delta variant versus the Omicron variant. And it looks like the performance of different rapid tests varies by which test you're using. You can see some of these tests here were much lower with the Omicron variant, but then some of them actually did continue to perform pretty well with the Omicron variant. I'm not sure what chambers of commerce are distributing right now, so you can go check what they are. But even if you have one of these rapid tests that doesn't perform as well, I'd argue if you can pick up 40% of infections that you might not have picked up otherwise, that's probably still of some value. And if administratively it's not too difficult to administer, I think there could be still some value to that. Key thing about rapid tests is how you take the sample matters, and this was one of the questions submitted in advance. If you take a sample where you swab the nose, you can see here it's about 2/3 accurate, but you get up to a little over 80% if you swab the mouth and then the nostrils. And so that is encouraged to hopefully get a more accurate result from the rapid test. That's not to say this is wrong. You're still going to pick up lots of infections this way, but to get the best uptake, best accuracy from it, you might want to encourage people to use the process where you swipe the throat, the inside of the cheeks and the tongue, and then actually swab each nostril right after with that same swab. Other thing to note about rapid tests is one thing we're seeing with rapid tests is that it's not necessarily going to be positive on the first day that people have symptoms, but maybe a day, 2 days later, it becomes positive. And so if you do have people who are sick with COVID-19, they take a rapid test and it's negative, I really do encourage repeating a day and 2 days later because you may actually pick up infections. And just anecdotally, I know lots of people who tested negative on the day they first got symptoms, and then the next day suddenly the rapid test came back positive. And so I think that is part of what is going to be important about using rapid tests, knowing that limitation. And then of course, rapid tests, if you're only testing once a week, there's a lot of days between those days you're testing, and it turns out you actually don't pick up many infections. When you test 2 or 3 or 5 times a week, you're more likely to pick up people. And so make sure if you do have a rapid test program, it is something where you're doing testing multiple times a week, and that's going to make sure you at least get the best yield and are more likely to pick up infections from it. So I'll stop there and turn it over to answering some of the other questions that have come in or which I didn't cover during my talk.
Dr. Hirji, thank you so very much for this informative update, and especially of taking a look at it on the long term, not just on what we're immediately facing. There's a couple of questions about the information that you had brought forward, and I was wondering if you can help us out with it. One of the areas that you had looked at was saying those individuals who've had COVID are at risk of developing some medical conditions, long-term ones related to cardiac, heart attack, and other things like this. Now, we have seen people have had COVID for the past 2 years. So we have some individuals who've had COVID maybe early on in 2020. Have other statistics that support that we have seen more people developing heart attacks, developing heart conditions, developing cardiac ones who've already had COVID?
Yeah, and that's the study that I was showing there, which was really looking at 1 year after infection. What are we seeing in terms of the cardiac illnesses? And the example I cited with the heart failure, 1 in 200 people who had COVID-19 infection is going to develop heart failure who wouldn't otherwise have happened. And so that's really, unfortunately, the issue with long COVID.
Now, these studies are looking specifically at COVID. Yeah. Can I assume that if people have had some other illnesses of some sort, that those would develop sensitivities towards some other long-term illnesses as well? Am I right? So if you've had developed some kind of a sickness, you would have had other symptoms too. So I'm trying to think of people who are maybe more prone towards having like lung disease and maybe have had cancer or other things that they had to deal with. Is this unexpected for us for COVID, that we are seeing the long-term symptoms? Are we? It's almost like it's a new territory. We knew in it, we did not know about it, but we do know if people have had other illnesses that there are long-term consequences for it.
Yeah. Did
we expect it for COVID as well?
Yeah, so I think it's new that we're seeing as widespread of these other, long-term symptoms, chronic illnesses occurring because of COVID infection. It's not entirely new that an infection would lead to chronic conditions. People who get a hepatitis infection, we know that increases your risk of developing chronic hepatitis longer term. And even actually developing liver cancer longer term. We know the HPV infection, if you get that actually is a cause of cervical cancer long term. HIV, back when we didn't have effective ways to control it, of course, led to AIDS, and it led to, all kinds of different cancers and unusual illnesses that people would have at that point. So it's not entirely unexpected, I'd say, but we've never seen an infection causing as much of this. That being said, this is also the first infection that we've probably had as much study on in terms of this. I really actually start to wonder if, maybe influenza has been causing some of this over a period of time, and we've just never really clued in on it. And we've, of course, had vaccines for influenza for much longer, so maybe that's helped as well. So right now, I'd say COVID-19, it's unique in terms of having as much and as broad the spectrum of chronic conditions, but I can say that it isn't happening with other infections. We've not noticed it before, but I don't know if we've studied it well enough.
No, that makes sense. Now, for all the participants that are listening to this and they're hearing this, and it's scary to hear that. It's not comforting overall. Are there things that they can do to prevent it, like to ensure that their long-term health is looked after? I know there are things that we can do to prevent it. It's vaccination, it's wearing masks, it's safety measures, and other things like this. But we've had a high number of individuals who followed all of the guidelines, who have had COVID, who are now in this situation. Some of them maybe not even being aware that they are going to deal with some long-term consequences to having had COVID. How can they deal with these potentially developing any of these medical conditions?
Yeah, so the first thing I note is that if you're a few months out from your infection and you haven't developed anything yet, that's probably a very good sign. Most of these conditions develop in the first 3 months or so after your infection. Some of them are like the cardiac ones, unfortunately, are a bit of a longer time frame, but most of them seem to be much more upfront, particularly even the cognitive stuff. That all occurs pretty quickly right after your infection. So if you've had your infection, you've gotten better, and you're not really feeling any ill effects, I think that's a really good sign. And hopefully you're in a good place as a result of that. The other thing is a lot of this data shows that it's much more likely if you're unvaccinated that you're going to develop those. And so if you've made sure you got your vaccines, that's going to give you greater protection going forward. And then I think it's what you highlight, that we want to make sure we minimize the number of times we're going to get COVID-19, hopefully even keep it to 0 longer term. And that's, of course, wearing masks when we're in places where, there's a large number of people, especially during times when we're seeing higher infections, making sure as new recommendations come on additional vaccine doses, we get those. And I think supporting our, organizations, supporting our governments to continue to take the pandemic seriously and put in place those bigger, broader changes in terms of ventilation, for example, that I think could reduce the risk of COVID-19 long-term in a sustainable way.
I look at your data that shows the hesitation of especially people in the middle age range, like 20 to 50, to actually look at a third vaccine or a fourth vaccine where applicable. There has been hesitation. The numbers have only shifted slightly, but probably not as much as maybe health professionals would have liked to see it. Some people, it is because they have gotten COVID. They think it's the natural immunity, as you had referred to. But I'm looking forward now at the fall. There's often the sense maybe we're all right during the spring and summer, and by the fall we likely or could potentially see an increase again, that we maybe are facing an additional wave that is there. As a health professional, do you look at it and saying, like, how do we now need to ensure that people stay safe and stay healthy, as this is likely maybe the uptake of the vaccine is not a choice that people are making right now?
Yeah, so I think a couple of things probably really helped us with the second doses as compared to the third doses. One, of course, the vaccine was new. The early data showed it was very, very effective. And I think people saw that we'll get vaccinated and this pandemic will hopefully come close to an end and we'll all go back to normal. And unfortunately, as it turned out how the vaccine, maybe the immunity waned a little bit, but particularly the Omicron variant, it seems like the vaccine, unfortunately, hasn't been as good as we had hoped. Absolutely still really good at preventing the serious outcomes, but I think that benefit is not quite as large, so people maybe have become a little less likely to get it. I think the shifting recommendation from the 2 doses to 3 doses may also have impacted people. I think it's maybe impacted some sense of the confidence around the vaccine, in the sense that maybe we didn't have it completely understood right from the start, which I think is true, but the only know how effective the 2 doses is going to be over the long term by observing it in the long term. And back in January 2021, we didn't want to delay, waiting another year to see how well the vaccine did and people were studying it. We wanted to make sure people had the protection right away. So it's unfortunate that I think it's played out that way, but I think that's probably hurt vaccine confidence a little. And then the final thing is that we had proof of vaccination requirements for a while where we were required to get those 2 doses of vaccine. And I think that nudged a lot of people who were inclined to get vaccinated. They just hadn't got around to it yet. And it gave them that nudge to hurry up and get it because it actually really have an impact on them if they didn't. And I don't think we have that nudge anymore for the 3rd doses. And people who've got 2 doses would probably be willing to get that 3rd dose, but there's nothing really pushing them to hurry up and get it. And I think those are some of the things that maybe are impacting us with that 3rd dose right now.
I think it makes sense. We have one of the questions actually relates exactly to what we were talking about, and we have asked you this in previous webinars, but is it time to change the definition of fully vaccinated to include the 3rd and 4th shot? You advocate for it, we know this, and I'm glad that you do. But overall, there is no uptake on it. Doesn't seem to be an appetite for it. So we can't immediately see it changing. What about you?
Yeah, it's a black box what's happening with this. These would be decisions made by the federal government, changing it to say that it's a recommended 3-dose series. I have no idea why they haven't gone there. I think everybody pretty much agrees this is a 3-dose vaccine at this point. The Ontario government has shifted its language slightly. It no longer talks about people being fully vaccinated. It talks about people being up to date with their vaccines. And the implication there is most people, if they're 18 or over, need to have 3 doses. So that's being up to date. People 80 years old and up 4 doses is being up to date. So they've adjusted their language there. I don't know why the federal government isn't following suit, because once they changed, I think that would basically cascade and make that fully vaccinated mean 3 doses for everyone.
Yeah. And that's always interesting to also look at what's happening in other countries too, because it all has an impact on us as we're globally connected. A couple of questions, as we only have about 10 minutes left. One of our attendees is asking, are employers required to screen employees coming into workplace? I know many places are not. And the same question similarly came forward relating to employees, but also to volunteers. And I think likely most workplaces have developed their own vaccine policy and how to deal with it. But what are your thoughts on it?
Yeah, there is no requirement to do that anymore. Those requirements were from the provincial COVID regulations, and those have all been repealed as of, I think, is April 27th or 29th, one of those dates. So there's no requirement to do it unless you happen to be operating a long-term care or one of those special sectors where the rules have remained. My strong encouragement would be to have some sort of expectation that employees self-screen, because if people have symptoms of illness, them staying home and not bringing the illness into the workplace is going to really help keep other people in the workplace safe and prevent destruction of your workplace. I think that's one of the sustainable changes that we can hopefully make in our society, basically make it a social norm that we're not going to show up to work when sick, and we're going to use some of our remote work options that we've developed over the last 2 years for those people to keep working if they really feel they need to work or feel well enough to work. And that's a way we can hopefully prevent. So it's really voluntary on workplaces to do, but something I would strongly recommend they do.
I have to say, from listening to our members and having conversations with them, a lot of business places have put this in place, and it's becoming much more of a practice than it has ever been when we look back 2 or 3 years ago. So it's good to see, and it's something that I think both employers and employees want to be in place, have in place as well. There's another question from one of our participants, and they're saying that during Easter, their entire vaccinated family of 11 caught COVID. This particular individual is vaccine exempt and could not get the vaccine, but exempted, but they also didn't get COVID, which was interesting. And they're wondering if you could explain how that is possible. The person that did not get vaccinated, they're also always on masks. They're very cautious at all times, and they're wondering if that makes a difference.
Yeah, it's hard to know exactly what happened here. One possibility, I don't know exactly the situation here, is that some people get COVID-19 and actually have no symptoms. So it's possible this individual maybe got COVID-19, never had symptoms. If they're doing rapid tests though and found that they remain negative, that they maybe actually been lucky and didn't get COVID-19. And it's all about probabilities in some sense, that you're most likely going to get infected, but there's going to be the odd person who gets lucky and doesn't get infected. So it could be luck there. I think wearing the mask, being cautious probably helped as well. I assume that when the entire family caught COVID-19, this individual probably tried to stay away from the rest of the family, so that hopefully prevented some exposure. So it's probably a combination of some good, masking and caution, as well as just some, random luck.
I'm shifting slightly only because we're getting into the summer. People are making travel plans, and I have to say, I'm curiously lived through everyone who's traveling right now. It's wonderful to hear, and so I'm glad to see it. And I think I'm glad to see it because I can see the mental health impact that it has, the positive impact it has for individuals to see something else, to be revitalized, to connect with family and loved ones again in very different places. But right now, airports are struggling to handle travelers while enforcing the COVID-related restrictions, and partially because they are also facing a significant labor shortage. I know it's not usually your area of it, but what do you see as the way forward for air travel when it comes to that?
Yeah, so I think the big measure still in place for airlines is wearing masks and having to show proof of vaccination, less for the airlines, more for the country you might be traveling to, including returning back to Canada. I think those are still good measures to have in place. If you think about an airline, you have a closed set of air, which is just recirculating to everybody. There is risk of people getting infected in large numbers in that airline. So having measures in place to limit that is good. Whether the, Arrive Can app, which I hear a lot of frustration directed towards, is the best way of administering some of that, I don't know. I'm not familiar enough with that. What I'd really hope for is that with much of the world having proof of vaccination as a requirement to enter their country, or at least enter the country and not have to quarantine, we would have some sort of international standard or international documentation that we could use, kind of like almost a password that's universally recognized, rather than every country doing their own thing. And I know for a while that there were efforts happening internationally to develop it, and I've not heard anything about that. And I think that's really unfortunate. If most countries are going to keep a requirement to show proof of vaccination, it would really be nice to have an international document that everybody could use. You show the same thing in every country, simplifies it, and hopefully reduces that administrative burden. So that's my hope of where this goes.
Yeah, mine too as well. Actually, it will make it so much easier as having something that's internationally recognized on that end. I am going to take 1 second to go away from COVID and look at other news items, because we've gotten specifically a question in this morning about it, and that has to do with monkeypox. They are wondering, is this taking over COVID? What is its role as we're moving forward? And I think it's a reflection, when I looked at the question coming in, I think it's a reflection of a community becoming more aware of maybe our vulnerabilities that we have overall. But I thought I'll give you a minute to maybe speak to that.
Sure, and I think we're still learning exactly what's going on with monkeypox in this scenario. So, I don't want to be too absolute in what we're going to see. I don't think that we're going to see monkeypox turn into another COVID-19, though. First off, monkeypox, we've known about it for 50 years. It's been in Africa for 50 years. It's popped up in other countries, and it's generally fizzled out. And as far as I know, there's no reason why that's going to suddenly change. The thing with COVID-19 that was different is there's a brand new virus, and of course, it had to establish itself, and it established itself by very quickly traveling around the world. Monkeypox has not shown that ability to travel around the world and infect people broadly in the same way. So most likely, I'm expecting this is going to be, we're going to see some infections of monkeypox that's going to fizzle out. It's not really going to spread much. In the past, we've not seen monkeypox spreads from person to person. It seems to spread much more from rodent type animals to people. It often is from direct physical contact. So you get a bite from an animal, you're handling an animal, and that's how you get infected. It seems like this one is maybe a little bit different, where there is some evidence that maybe there was person-to-person spread, particularly amongst people who are sexual contact. So that kind of makes sense. You have that direct personal contact. It doesn't seem like there's a lot of evidence yet to suggest that it's changed the way it's going to transmit and it's going to start to spread, the way COVID-19 has, isn't going to become a real big issue. That being said, we could always be surprised something else could emerge. Maybe there's some sort of new variant of monkeypox, but unlikely. Just the nature of this virus is one, it doesn't mutate as much. So my sense is this is going to be more like, Ebola we had a few years ago, or Zika virus we had a few years ago, where it's a concern, some infections pop up, we kind of contain it, and it doesn't go too far.
Very good. May I ask you to come back one more time to COVID? Dr. Hirji, we have spent many hours in this Espresso format. We're now in May of 2022. Are you optimistic looking at the fall? Are you optimistic looking at the winter and looking at us moving into 2023?
I hate to be a little bit of a naysayer, but I'm not that optimistic. I am optimistic for perhaps the next 2 to 3 months. I think we'll hopefully benefit from people being outdoors, heat, humidity from summertime really impacting the ability of the virus to spread. And I'm hoping we get something closer to the last 2 summers where we don't see a lot of COVID-19 going around. I really do worry, though, what we're going to see in the fall. Kids are going to go back to school. Everybody's going to be back from vacations, going back to work. It's going to get cooler. We're all going to be indoors, and we'll be several more months out from our vaccine doses. There might be some more waning, and that could be the scenario that allows more infection to start to spread. There's a new variant that could add to it as well. I do think there is a real opportunity, though, here for hope. We've learned a lot in the last 2 years about how COVID-19 spreads, and we can hopefully use the next few months to put in place some of those sustainable long-term changes in our society that can keep us protected longer term. If we can retrofit along of our public places to have better ventilation filtration systems, put up the money so we can do that, that could really make a big impact on infection spreading. Talked about rearranging our holiday calendars, those sorts of things, doing more to get those 3rd doses of vaccine up. I think there are things that we can hopefully do so that my pessimistic scenario maybe doesn't transpire as much as it does. I'm not feeling a lot, though, that governments are very focused on that, and that's my big concern. And I'm hoping maybe once the election is over, maybe people will maybe refocus on this a little bit more. But unfortunately, I have not seen much talk about the pandemic and what they're going to do in the election platform. So I'm a bit pessimistic. We're going to do what we hopefully should be doing over the next few months to be ready for that fall surge.
Yeah. And I think a lot of the things that you mentioned are really things that need a longer term impact. We can retrofitting a building is very difficult to do and to move forward. And these are long term, these are 5-10 year kind of projects where we need to move forward overall. Nevertheless, I want to thank you for being with us.
And the other thing I'll just highlight is, of course, we think about something like the restaurant industry, one of the highest risk sectors for infection spreading, and they've had so much disruption, not been able to operate. They're just trying to get on their feet. They can't afford to do that. We need to have government funds and government programs to make that happen.
Yeah, and many of the people that are in certain buildings, in office spaces, they don't own.
Yeah.
Over 90% of small businesses don't own it. I can't retrofit my office space right now, so I depend on others at the same time too. But overall, on behalf of our members, the business community, as I said at the beginning of it, thank you so very much for your time that you have spent with us. We really appreciate it, and also your sense that you're available to us, that you're able to share it with us. And even if we see any, hopefully we won't see any more dramatic changes, that we can call on you as well. So thank you for all of that. And to all of our participants, thank you for being with us so regularly for these Espresso Live webinars. As always, they are being recorded and will be available on our site. Dr. Hirji, thank you so very much.
You're very welcome.
Bye-bye.